Welcome to today's webinar entitled Safeguarding Transplant Recipients, Measles Risk Reduction Strategies. The presentation today is being sponsored by the Transplantation Society in collaboration with the Transplant Infectious Disease section of TTS. My name is John Baddley, and I am a professor of medicine and director of the Transplant and Oncology Infectious Disease Program at Johns Hopkins in Baltimore, Maryland. I also serve as the president of the TID section of TTS. My co-moderator for the session is Stephanie Pouch, who is an associate professor of medicine and director of transplant infectious diseases at Emory University in Atlanta, Georgia. Thank you for joining me today, Stephanie.
Thanks so much. The recent global increase in measles cases really does pose a unique threat to transplant recipients. And we wanted to take the opportunity today to discuss the epidemiology of measles, its clinical features in immunocompromised patients, as well as prevention and treatment strategies. We're looking forward to 3 presentations by our distinguished speakers, followed by a live panel discussion. Now, we do really aim for this webinar to be interactive, and we encourage you to please enter any questions into the Q&A window during the presentations today, and we'll try to answer as many as possible at the end of the session.
Thank you. It is my pleasure to introduce our first speaker, Dr. Ricardo, who is an associate professor of medicine and director of transplant infectious diseases at UT Southwestern Medical Center in Dallas, Texas. He also serves as the current chair of the American Society of Transplantation Infectious Disease Community of Practice. Dr. Laus will be discussing nuts and bolts of measles for the transplant specialist. This will include discussions on measles transmission, clinical manifestations of disease in solid organ transplant patients, diagnosis, treatment, and prevention of donor-derived infection. Thank you for agreeing to be a speaker today, Ricardo.
Well, thank you very much. I would like to thank the organizers, TTS, TID, John, Stephanie, Camille, and Lara for the invitation to speak today. It has been a pleasure working with everybody towards this webinar. So I don't have any disclosures. So measles outbreaks pose a threat to both pre and post organ transplant recipients. Since the first description of measles in the 10th century, we've really accumulated a fair amount of information regarding the epidemiology of measles, route of transmission, risk factors, etc. This information we can use to ameliorate the burden of measles in the transplant population. Measles is a very contagious disease. One person can spread the disease to up to 9 unvaccinated people around them. Furthermore, the disease is transmitted via airborne routes when an infected person sneezes, coughs, or even breathes. So the first topic that I want to clarify is what is a presumptive evidence of immunity? And the CDC defines it in any of the following ways. Number 1, laboratory confirmation of disease, because reinfections are exceedingly rare. Birth before 1957, because everybody's assumed to be exposed who've had the disease before that time. Written documentation of adequate vaccination with MMR, and 2 doses at least 1 week apart are required during an outbreak, because this schema is highly effective. Or laboratory evidence of immunity via measles IgG. Patients not meeting the above criteria are considered non-immune and should be vaccinated unless contraindicated. And we'll address that further down the talk. The next thing that we should speak about is what is a measles exposure, because it's important that we educate our patients on how to precisely identify an exposure. And it's defined by sharing the same airspace with a person with measles during the period that they're known to be contagious, and that's 4 days before until 4 days after the rash. It's very important to remember that measles can live up to 2 hours in the airspace, and thus we need to factor this when we define the exposure. For example, a patient comes in, is in a room in clinic, and we will have to consider that anybody is exposed for 2 hours until that patient left the room. Now I would like to speak about what is the clinical presentation of measles in general, and this description is mainly for immunocompetent patients without prior immunity that did not receive post-exposure prophylaxis. And I will then address what the nuances of the presentation in immunocompromised host. So these are the stages of the disease. The incubation period really lasts 6 to 21 days. And like I mentioned, the period of contagiousness is 4 days before until 4 days after the onset of the rash. During the prodrome, the typical symptoms include fever, malaise, anorexia, conjunctivitis, and coryza. And all these symptoms are the result of mucosal inflammation from the virus. The next two stages in the infection are the enanthem and the complex spots, although they're pathognomonic of measles, unfortunately, they do not occur on all patients. These lesions appear about 48 hours before the onset on the rash. They're on the buccal mucosa, usually found at the level of the molars, and they're described as 1 to 3 millimeters small sandy-like lesions with an erythematous base. It's important to mention that these lesions only last 12 to 72 hours. So, and then they start sloughing away as the exanthem happens. The exanthem is the rash. The rash usually starts in the face and then it propagates in a centrifugal and manner to involve the neck, torso, extremities, and lower extremities. When we speak about the immunocompromised host, we need to speak about complications. The complications are most frequently observed in children rather younger than 5 years of age, adult over 20 years of age, pregnant women, malnourished, and immunocompromised patients. There's a series of complications, but I'm just going to be addressing the first 3 today. The respiratory complications. Pneumonia is the most common cause of measles-associated death in children. And any part of the respiratory tract can be involved with bronchopneumonia, laryngeotracheal bronchitis, bronchiolitis, and measles is even associated with the development of bronchiectasis and then subsequent bronchiectasis exacerbations. The neurological manifestations will depend on the type of host, the age at which the infection was acquired, and then the time course. So for example, ADM happens in a normal host, usually when the infection is acquired after 4 years of age. And this complication is thought to be the result of an immune response. So the measles virus is not in the brain, and it usually happens 2 to 4 weeks after the initial infection. Measles inclusion body encephalitis is a presentation that's unique to immunocompromised hosts. It can happen at any age, and there is evidence of measles in the brain. It's usually progressive within months of the initial event. Then we have subacute sclerosing panencephalitis that again happens in a normal host, usually when the infection is acquired before 2 years of age. And it tends to happen within years of the initial infection. Additionally, measles is really a fascinating infection because after it happens, there's a fair amount of effects on both T cells and antibody production. As a result, patients that had measles are at risk for secondary infections with bacteremia, viral, bacterial, respiratory infections, as well as otitis media being the most common. But there's a clear association also between measles and a risk of tuberculosis reactivation. These effects may even last for up to 3 years. Now, what are the nuances of the presentation in immunocompromised host? The solid organ transplant recipients are expected to be at risk for severe measles, and there's a case series describing that, and a higher risk of complications and mortality are expected. The rash is really associated with the onset of immunity, Thus, solid organ transplant recipient may present without the rash or a very atypical mild one. Some things to take into account when you evaluate patients during an outbreak is that giant cell interstitial pneumonitis and inclusion body encephalitis have been described in immunocompromised patients where the rash was not present. Now let's move gears to diagnosis. It is very important that we test patients with a compatible clinical presentation to maximize the diagnostic performance of our assays and avoid false positive. We should test all patients suspected of having measles by serology, both with IgM and IgG, and a real-time PCR to optimize the sensitivity and specificity. And now I'm going to go through some of the nuances of this test. The IgM is mainly used to diagnose acute illness. It appears as early as 1 to 4 days of rash onset, but it really peaks a week after the onset. It is most sensitive after 3 days after onset of the rash, and it can remain positive for 6 to 8 weeks. False positives are unfortunately, are common, and that is why we need to test patients with a good clinical suspicion. The sensitivities of serologies in general is expected to be decreased in immunocompromised hosts, and we need to interpret the results with caution in those receiving immunoglobulins. IgG is predominantly a test for pre-existing immunity. So if you test a patient and you detect IgG at the time of onset of the rash or at the time of exposure, this would just mean prior immunity. Again, we need to interpret the result with caution. There's a very peculiar scenario in which a patient may have a compatible presentation with measles, and the only positive test is the IgM and the PCR are negative. You could actually test the IgG both negative as well as the real-time PCR. You could test that patient 10 days later, and if the IgG becomes positive, then that will further support the diagnosis, just to be sure that it was not due to a false positive IgM. When it comes to PCR, we should make efforts to obtain a throat and nasopharyngeal swab in suspected cases. The sensitivity is highest after 3 days of onset of the rash, but it can remain positive for about 10 days. Urine may also contain virus and when feasible should be tested to increase the sensitivity. It is important to note that the commercial assays cannot distinguish between vaccine-derived virus or wild-type virus. So for example, if you have a transplant recipient that was vaccinated after an exposure and unfortunately developed signs compatible with measles, you may not be able to tell if it's infection due to the virus or due to the development of infection. And in those scenarios, you could use the measles vaccine assay that is available through the CDC that will be able to differentiate those two. There's also genotyping testing that could be done in some particular scenarios. So the treatment for measles is supportive. There's no specific antiviral therapy that is approved for treatment. There's very peculiar rules for the use of vitamin A, and there is insufficient evidence to recommend at this point the use of ribavirin for the treatment of measles. Now let's change gears and let's speak about the prevention of donor-derived measles and measles vaccine virus. Some things to take into account is the organ procurement organizations should elicit a history of prior measles vaccination, measles exposure, and they should be familiar on how to recognize signs and symptoms compatible with measles. They should also evaluate the organ donor for secondary infections because the risk of transmission may not only be due to measles, but that that donor may have other infections that will be worthwhile evaluating for. The first scenario that I thought about was a donor with a history of measles vaccination. This is a scenario that poses a minimal risk to the OPO and recovery team but there's a risk of donor-derived measles vaccine virus. The classic teaching has been to defer donation for 4 weeks after the initial and the second dose, but Lara is going to be presenting some emerging data. The second scenario that I thought about was the prevention of donor-derived measles in a donor with measles exposure. And the truth is that the ideal timing of donation to minimize the risk of transmission is really unknown. But this scenario poses a risk of transmission of disease to the OPO recovery team as well as donor-derived. Donation should be deferred for 21 to 28 days, and 28 days will be for those that received immunoglobulins for post-exposure prophylaxis. When we think about the risk of transmission, we should also evaluate the intensity of exposure and the prior history of the donor. Those that have a history of being unvaccinated will have a higher risk of developing measles and thus transmitting disease than those that are vaccinated or those that have natural infection. The risk of donor-derived disease needs to be balanced against the risk of pre-transplant mortality. The second scenario, or the third scenario, is the donor that actually has a history of measles. And again, unfortunately, the ideal timing of donation is unknown, and this donor may pose a risk to the OPO and recovery teams as well as donor-derived infection. But then, like I mentioned before, remember that these donors may also have secondary infections that you may need to evaluate the donor for. Donation should be deferred for at least 4 days after the onset of the rash, and this is based on studies on patients pre and post-mortem using culture techniques. And the onset of the rash correlates with immunity, and those studies suggest that after 4 days, there is no further infectious particles. At the same time, it is unclear, like I mentioned, what is the ideal time. Again, it's always important to balance the risk of donor-derived disease against the risk of pre-transplant mortality. And that is the end of my presentation.
Thanks so very much, Dr. Lojos, for that fantastic overview. Before I introduce our next speaker, I just wanted to remind everyone who's joining us today to please go ahead and enter any questions you have in the Q&A or in the chat, and we'll work to get to all of those during the question and answer session at the end of the session today. So I'm now pleased to welcome our second speaker, Dr. Camille Kotton. Dr. Kotton is the clinical director of the Transplant Immunocompromised Host Infectious Diseases Program in the Infectious Diseases Division at Mass General Hospital and is an associate professor of medicine at Harvard Medical School in Boston, Massachusetts. She has also served as the president of the Transplant Infectious Diseases section of the Transplantation Society and is the current secretary of TTS. Dr. Kotton will be discussing measles prevention in immunocompromised hosts today, and I'm really looking forward to your presentation.
Thanks very much. It is a real pleasure to be with everyone today and talking about this and how we can protect vulnerable populations. And so I will talk specifically about prevention in this population. I have a few disclosures, as you can see listed on this slide. And so I will talk about pre-transplant vaccination, post-exposure prophylaxis, and then I'm going to turn things over to have Dr. Danziger-Isakov talk about very exciting work she's done largely in pediatrics with post-transplant vaccination. So I wanted to frame things with a little clinical vignette. A 57-year-old organ transplant recipient in New York City comes to transplant clinic for a routine visit 3 months after emergent liver transplant. He was measles seropositive at the time of transplant after many transfusions and fresh frozen plasma. The astute infectious disease specialist noted that prior measles serology in the outside record was actually negative, so it looks as though he has a false positive measles titer from all of the transfusions and the plasma. He reports not feeling well for a few days, and on exam, he has a fever and a rash. He was sitting in the crowded transplant clinic waiting room for an hour before the visit. So what do you do now? And so let's address this. So let's think overall about organ transplantation and the scope of the problem. You know, the majority of current transplant recipients in the United States were born after 1957, so are not protected by natural disease, and before the late 1970s. This is the cohort at highest risk for for having poor protection against measles, because in the late 1980s, we realized that people needed a second dose of MMR vaccine. If we look at various series, there's a series from Houston where 20% of transplant candidates were measles seronegative. In another series from Salt Lake City, 13% were measles seronegative. In a series we did at Mass General, it's about 5%. But you can see this is a high-risk situation as far as who's undergoing transplant, who's already had a transplant, and who is most vulnerable. So where possible, we should be testing measles IgG prior to transplant. Do be aware that they could be false positive if they've had recent administration of blood products. And if measles seronegative, think about vaccinating them prior to transplant with at least a 1-month washout before undergoing immunosuppression. And in general, I find that close to half of the patients I see might not be able to get MMR vaccine. And I say MMR because it's only available as a trivalent vaccine. There's no monovalent measles vaccine, but they may not be able to get this prior to transplant either because of time or current immunosuppression. So easier said than done. I also want to highlight something that's important to know about, which is that before giving MMR vaccine, you should make sure that people have not had recent transfusions. If they've had a recent red blood cell transfusion, they should wait at least 3 months before undergoing MMR vaccination. And as you can see, it's sort of 8 to 11 months for various IVIG preparations before undergoing live viral vaccine, either with MMR or varicella. And so that's something else that kind of throws a wrench into the works. Also, if you think about the duration of those blood products and how long people might test falsely measles seropositive, this can sort of be helpful when you're trying to evaluate someone's serology. How is that decision made to wait a month before immunosuppression after MMR vaccine? And, that's a recommendation from the CDC and IDSA. And basically, it's because they can have symptoms of fever, febrile seizures, transient rash for up to 2 weeks after administration. So it was sort of estimated that we should wait twice as long, so 4 weeks or a month, before starting immunosuppression. And we'll talk about that in a little more granular detail. I will say that it's not entirely clear how many doses we should be giving. Perhaps in a perfect world, we should be giving 2 doses of MMR, especially if we're not sure if they ever had any. But I would emphasize that most people in the United States and North America have had at least 1 dose of MMR for school entry and whatnot. So it would be pretty rare that you're seeing people who are completely naive. So often when you're giving a first dose as an adult, it's probably a second dose, but you may have incomplete records. So lots to think about. I do think that in general, the immunocompromised patients do better with more doses of vaccine. If we give just 1 booster, there might be a shorter duration of protection, and there is a higher risk of severe disease. So we don't have an official recommendation in this setting, especially where we may not have accurate records. What are the risks of vaccination in immunocompromised patients? Well, it's pretty rare, but they can develop measles pneumonitis, and they can get a vaccine-associated inclusion body encephalitis, as has been reported here. So rare, but these are things that we would want to avoid because they could be life-threatening with no reversibility. So we will talk further about this, but who could be vaccinated? There will be data presented in the next session by about pediatric and young adult solid organ transplant recipients on low-dose immunosuppression who could be safely vaccinated, stem cell transplant recipients who are more than 2 years out from transplant, haven't had recent IVIG and are off immunosuppression, and perhaps more than a year out after CAR T-cell therapy, as long as they're no longer immunocompromised. But in general, we would not recommend vaccination of adult solid organ transplant recipients, especially at older age or with multiple immunosuppressive agents or comorbidities, or recent stem cell transplant recipients or recent CAR T-cell recipients. We would emphasize that all household contacts should be vaccinated, and we get a lot of questions about whether it's safe to vaccinate household members against MMR, and the answer is yes. That is not a contraindication. So we actually want to cocoon or protect the immunocompromised patient by having household contacts be vaccinated. And similarly, medical staff should all be well vaccinated, and that's usually pretty straightforward through occupational health. I'm now going to talk about post-exposure prophylaxis. So the CDC back in 2013 developed guidelines that severely immunocompromised patients who are exposed to measles should receive intravenous immunoglobulin prophylaxis, regardless of immunologic or vaccination status, because they might not be well protected by vaccine. And this could be intramuscular if they weigh less than 30 kilograms, but most adults weigh more than 30 kilograms. So usually it's IVIG at 400 milligrams per kilogram, which is a pretty big dose. And, you know, they defined in that guideline back in 2013, severely immunocompromised patients, as you can see there, they don't specifically mention transplant recipients. So it's really hard to know based on those guidelines what the current recommendation would be. We did upgrade the definitions of moderate to severely immunocompromised people during the pandemic, as you can see there, and that includes solid organ transplant recipients. So we don't have further guidance from the CDC, and this is sort of a problem now because we don't know how we should best manage organ transplant recipients. However, in happy news, the Canadians just updated their guidelines on who should get post-exposure prophylaxis. And they recommend that anybody who's within 12 months of solid organ transplant should be offered post-exposure prophylaxis through the form of intravenous immunoglobulin because they may not be well protected. They then go on and say that people who are more than 12 months out from organ transplant, especially those who are seropositive, may not need IVIG, but people who are seronegative may need IVIG. You can see in the column on the far right, these are pretty soft recommendations, and they say to consult the specialist responsible for the clinical care of the individual, which means many people on this webinar. But I found that this is more granular, it's up to date, and I thought more helpful. Post-exposure prophylaxis, just a couple more things. For people who are routinely getting IVIG replacement, as long as they're getting a significant dose of at least 400 mg per kg within 3 weeks before the measles exposure, that should be sufficient protection. And for people who are getting ongoing subcutaneous immune globulin therapy, as long as they're getting at least 200 mg per kg for 2 consecutive weeks before exposure, that should be sufficient coverage. How effective is this overall? This was a recent series predominantly in children, but it does look as though the effectiveness was sort of 76 to 100%. And I just wanted to mention a recent study that I was involved in partnership with Kamada. We tested measles IgG titers in various intravenous immunoglobulin preparations, as you can see in the first 3 columns to the left on the graph. All of these donors were from Europe or the United States. And what was interesting in CMV immunoglobulin preparations, it looks as though there's twice the amount of measles antibody in serum compared to in this product compared to all of the other products as shown there. So we don't know what to do with this. We can't really make formal recommendations, but if we are in a time where we are beginning to run out of IVIG, this could be helpful information in that perhaps we could give half the dose of cytogam and help enhance protection for more people if rationing is needed. So some challenges, this high dose of IVIG takes at least several hours to infuse, if not 4 to 6 hours. That would have to be done under strict respiratory infection control because all of these people are measles exposed and measles is highly contagious. And you might not want to have all of these people if they are immunocompromised in the same area. So that's already challenging. This requires an infusion suite or hospital level care. The cost likely starts at several $1,000s. Local IVIG supplies may not be robust enough in an outbreak, and so that's food for thought. And the duration of protection is unknown. So if it's an ongoing outbreak, when should we redose? We do need PK/PD studies. It will be hard to know exactly what to do in that scenario. So just returning to the clinical vignette, The important thing here is to screen and notify everyone in the waiting room, think about isolation and infection control, and consider IVIG for at least some of the people in the waiting room. But it's good to prepare for moments like this. There are many unknowns with post-exposure prophylaxis. We don't know whether measles IgG seropositivity conveys adequate protection. It doesn't necessarily directly correlate with neutralizing antibody. And is it different in the first 12 months after transplant versus more than 12 months after transplant? We don't have great definitions for who is severely immunocompromised and at highest risk for this. And how adequate is the evidence of measles vaccination for this population? Even healthy vaccinated people can get measles, so what does it mean for these folks? And then I sort of made a list here of who is at highest need for measles post-exposure prophylaxis. In general, we would think that the unvaccinated with no history of disease and significant immunocompromise would probably need IVIG most of all. People who are non-immune within the first year after transplant or non-immune more than a year after transplant. And then we think that people who are immune, previously well vaccinated within a year of transplant probably need this a lot less. And similarly, number 5 would be more than a year after transplant and presumed protected. So we believe that those numbers 4 and 5 need it less. Although the Canadian guidelines suggest that number 4 does need IVIG. And then we don't really know how effective IVIG is in transplant recipients in real clinical settings and how long the duration of protection would be. So there's so many unanswered questions. I just highlight that we did address some of these questions in a recent commentary that we wrote in the journal Transplantation last summer. And thanks for, and just in summary, vaccine preventable illness occurs at higher rates in this vulnerable population. Timing of vaccines is paramount, and just everybody hopefully has pre-transplant vaccination planning underway. If you haven't been doing it, no time like the present to get started. We've been doing it for over 20 years, and I initially had some resistance to that, but now I'm glad we've been doing it. And measles can be prevented by a generally safe and well-tolerated vaccine before the start of immunosuppression. IVIG, post-exposure prophylaxis, is likely indicated for at least some transplant recipients. But most of all, and this is an across-the-board statement, none of your transplant recipients should be developing vaccine-preventable illness if at all possible. So thanks a lot for your attention, and I will now pass the baton to the next speaker.
So Dr. Kotton, thanks so much for your excellent talk. That was really wonderful. And just a reminder, please enter your questions and answers in the box. We have a lot of great questions so far, and we're looking forward to more. I would like to now introduce our final and third speaker, Dr. Lara Danziger-Isakov. Dr. Danziger-Isakov is a professor of pediatrics at the University of Cincinnati, where she is the director of the Immunocompromised Host Disease Program and also serves as the interim division director. She will be discussing opportunities for early prevention of measles, including post-transplant vaccination in pediatric and young adult patients. Thank you, Lara.
Thanks, John. Thanks, everybody, for joining. I'm really going to try to get through this so that we have plenty of time for our discussion. So I'm going to talk about opportunities for prevention, and this is planning ahead so that we can avoid some of the things that Ricardo and Camille have already addressed. These are my disclosures. I'm going to talk about vaccines, when and how. I think to start on the timeline, really what I'm going to talk about first, which has been addressed already a little bit, are these pre-transplant, transplant evaluation, and transplant listing. First, I'm not going to talk about vaccinating during transplant in the early post-transplant or with recent rejection, because that isn't part of the current protocol or the current evaluation and recommendations of what we've done. And I'll talk about post-transplant afterward. I did want to highlight some emerging data, and I will say the caveat to this is that nearly all of the data that I'm going to present is in pediatric patients and patients who are pediatrics, adolescents, and young adults. There's very little information about vaccination of adult transplant candidates and recipients. So this was a great study that was very small, but done out of University of Colorado with Sarah Camille and Amy Feldman, among others, where they looked at patients pre-transplant and compared them to healthy controls, giving them MMR and varicella vaccines. And I'm going to highlight the MMR vaccine results. They measured after vaccination over time to see when measles virus was present in the bloodstream, peripheral bloodstream of these patients. And as you can see here, this is at 28 days for all the 12 healthy controls. None of them had measles virus RNA PCR detected. And then they went week by week with the transplant candidates. These are patients getting their first vaccine. There are obviously not very many of them. There's 21, largest study to date, but still a small number. And certainly we can't extrapolate all safety from this as well as duration. But you can see here that by 14 days, there was no evidence of replicating of viral RNA detected in the patient population. Okay. I will state, we do know that there are vaccine recommendations. And when we're thinking about this, this is the routine recommendation that for infants and children especially, if a child is going to be traveling internationally, and this is in a non-outbreak setting, they can get their vaccine early. But they still are required to get the 2 regular doses after 12 months of age. Obviously, the recommendation is 12 months of age and at dose 1, and then 4 to 6 years for dose 2. An accelerated vaccination schedule, which can be utilized for pediatric transplant candidates, as well as patients who are younger, who are in an area of an outbreak, or who are going to be traveling to an area of an outbreak, which is a common question that we currently get. If they are young, 6 to 12 months, they're eligible to receive a vaccine, potentially, but they still will need 2 doses after 12 months of age. And the same is that you can accelerate your second dose of vaccine 28 days after the first dose. So this is important to remember when we're thinking about protecting communities as well as our transplant patients, even at the youngest ages when they're most vulnerable. Now I'm going to focus a little bit on the post-transplant vaccination, and I'm going to start with the study that really kicked this all off for MMR. This is a study by Laura Pate and Clara Pasve-Barb out of Switzerland, where they took 90 pediatric liver transplant recipients who were on monotherapy and were with a single calcineurin inhibitor, and they screened them to see if they were seropositive. If they were seronegative, 44 of them received between 1 and 3 doses of MMR in the post-transplant period. And you can see here that after this primary vaccination, the majority of them had evidence of seroprotection, 100%. And there were no serious adverse events reported and no breakthrough disease. And there was a significant increase in the measles-specific IgG. Now, there is a hint here that perhaps this isn't sustained year over year with positive IgG, and we'll come back to that in a few minutes. So this led to the recommendation in the 2019 AST/IDCOP stating that MMR and varicella vaccination are generally contraindicated, but may be administered in these careful settings with appropriate education and close follow-up. And there were still many outstanding questions about durability, patient selection, and if there's biomarker prediction for response. In 2018, the Toronto Consensus Conference, which is a group of infectious disease, immunology, laboratory-based practitioners, as well as organ-specific practitioners, met and developed a kind of a red, yellow, green stoplight scenario of how to approach post-transplant vaccination. And you can see here some of the recommendations that they had about when to be more cautious. Obviously, patients who are on enhanced immunosuppression or patients who had evidence of functional tolerance. There were certainly patients that were suggested not to. And I think what happened next was actually even more interesting, is that a group of individuals got together and pooled their information. This is the LiveVac Consortium, which is an observational cohort of solid organ transplant recipients. And I will say primarily liver recipients, although there are kidney recipients in this cohort, as well as other work that's been going on in heart recipients, although that is very early data. This is data that was published in 2023. It is 236 patients received an MMR vaccine in the post-transplant period. Most of them were significantly several years post-transplant, obviously adolescents, children, young adults, and one of the biomarkers that we did look at, 98% of them had a normal absolute lymphocyte count and an IgG that was in the normal range prior to being vaccinated. I will note here that 26% of them, opposed to what the Toronto consensus suggested, were on 2 or more agents. And this included a calcineurin inhibitor with an mTOR, or actually 7% of these patients were on MMF. Importantly, you can see here, and I've included all of the things that we looked at. This was a small group that of these 236 who had serologic response reported at the time. And you can see here, actually, many of them developed antibodies, and 1 year post-vaccine in this early cohort, 92% of them had sustained response. I will also say that there were no episodes reported of serious adverse events related to MMR, and no patients developed anything that was considered to be a measles-like rash. I will say that we did distinguish low, medium, and high levels of immunosuppression. The low level would be most similar to what was in the original study from the Swiss cohort. The medium, as you can see, is two or fewer agents, which may or may not include steroids, at a low trough level, combined trough level, and a high was at 3 or more agents. When we looked at the 1 year follow-up data, which was just published last month in JAMA Peds, we found 188 patients. 30 of them had not responded or below the level of seroprotection detection, and 158 of them had responded. And the thing that was significant was that of the non-responders, a higher proportion of them were on high levels of immunosuppression. Again, no serious adverse events, no measles-like rashes were reported. And that was their early antibody response. At 1 year, we looked and we had fewer of them that reported this, but this appeared to have been at least abrogated somewhat. It may be a reporting bias of who had their titers tested. Okay. Coming back to the Swiss cohort, they again looked at this over a long term, over 9 years, and did show that seroprotection, evidence of seroprotection did wane. Repeat vaccinations were used. And I think that this is an important point, that we may need to keep monitoring patients beyond the initial vaccine. So I think my summary is that we should identify every potential opportunity for prevention. In pre-transplant, we need to start as early as possible, including infants who are under 6 months to 12 months of age. For post-transplant, even if we vaccinate, we may need continued reassessment of these patients to ensure continued seroprotection. And we should also include family members and healthcare workers just to ensure safety and the cocooning that will help our patients remain safe. Thank you.
Thanks so very much, Dr. Danziger-Isakov, for that incredible presentation. We are now going to move on to our live panel discussion. We have several questions that are really important to address, and we're going to be working to get to those. But I do encourage you to continue posting questions in the Q&A. I'm going to start by beginning the panel discussion by asking our panelists a little bit more about vaccination with respect to timing of transplantation. What are your thoughts with respect to special situations that may arise where a transplant candidate has been vaccinated in shorter than a 4-week duration prior to an organ offer, but it may be a special situation with respect to that organ offer? So the transplant would be imminently life-saving, or there's an excellent immunologic match. How do you proceed in those situations, and would you do anything differently?
I guess I'll take this one first. I think this is a really individualized conversation to balance all of those factors. In our experience, it depends on several things. One, it depends on, is this the first time they've been vaccinated, or is this the second vaccination or third vaccination? And what is the likelihood that this individual will get another offer? How close are we to, 3 weeks, 4 weeks post-vaccine? If it's 2 days, I'm going to feel much less safe suggesting that. But if we're talking 19, 20 days, and it's their second vaccine, and their individual isn't on other immunosuppression leading up to the organ offer, and this is their only organ offer that they're going to get, they've been waiting for, months and months, or they're critically ill, I'm going to probably have a different answer. But it's a continuous conversation within the team. And it's really building that trust within the team to know that you're making a collective decision that's the best for the patient at that moment.
Yeah, I think I'll have little to add what Lara said, but I'm not sure that we know in the adult world, but everything that we do in transplantation has pros and cons. And I think the ultimate goal is to minimize both the pre-transplant mortality and the risk of measles vaccine virus complications post. So those that decide to give 2 doses could be faced with 2 months wait period. And again, you may not choose to do that on somebody with a high MELD score or somebody with a high LAC score or that. But ideally, if we're in an outbreak, we could transplant those patients for then unfortunately be exposed in the community. So in the ideal situation, we'll try to get them to transplant with enough immunity to minimize them. But it's hard to sort of quantify the net state of immunosuppression, ICU stay, comorbidities, immunosenescence, and so many other things that could add up to the risk of measles vaccine virus disease. But I would say that we do have some data. There's data on the duration of viremia in humans, and I quoted some of those studies. There is data on a macaque model of measles. And there is the study that Lara quoted on pediatric patients that were vaccinated and the PCR was measured weekly. And in all of them, the period of viremia appears to last less than 2 weeks. Now, if there's a virus in the tissue, we don't know. But we could also give IVIG in that scenario, and we've had to do that a couple of times here where we vaccinated somebody, they unfortunately get sick, and we proceeded with IVIG. So I do think that the ideal situation is 4 weeks, but there is some data that could justify a shorter period, in particularly after the second dose, where we would expect the prior immunity to make that period of viremia short.
I would just like to add, there's a question for critically ill pre-transplant patients who are in the ICU waiting for an organ. Would we vaccinate then? And I would just like to say no. I don't think that that is a safe practice. They may undergo transplant, hopefully within the next few days if you're lucky. So I would not be vaccinating in that circumstance. I would really, unfortunately, not everybody can be vaccinated safely. So it's, as we said, always weighing risks and benefits.
Great, thanks so much. So another couple of questions about post-transplant serologies, be it stem cell or solid organ. Should patients who may have already been immune get checked for serology in the context of outbreaks in the area? Any thoughts on that, Camille or Ricardo?
Go ahead, Ricardo. You.
Oh, I think it is. I would say that there's a fair amount of things to take into account. Number one, pre-transplant vaccination, and we know that the immunity is going to wane down. So, and then number two, logistics and the capabilities to really answer questions from patients. So, what we've done is we've generated a document or different documents for our pre-patients and our post-patients. And it will be challenging to check serologies in all of our posts that we follow, I think, more than 4,000 patients to check in all of them. And then what is going to be the actionable item? Many of them, adults, we won't be able to vaccinate. And if exposed, many of them may still require post-exposure prophylaxis. So I am not sure that there's a lot to be actionable by doing that if you have a history of vaccination, a history of infection, and so forth. But let's see what Camille says.
I agree entirely. Nothing to add.
Thanks.
Okay, we've had a couple of questions come in about measles diagnostics. I'm actually going to go back to that topic and perhaps direct this question to Dr. LaHose. There are questions regarding diagnostics for measles early on, particularly when an individual may start to have prodromal symptoms. So in that situation, would you prefer urine PCR versus PCR testing from alternate sites, and how would you proceed in that particular clinical context?
Okay, I have a slide for that. Actually, somehow I predicted that question. So I think most of the assays lack sensitivity before the 3 days after onset of rash. So I think there's, again, multiple pieces to the analysis. And number one is the exposure that the patient that we are evaluating may have. And again, we've defined exposure, but the intensity of the exposure. Number two is the presentation. And that could be challenging during the respiratory season because many fever and coryza could mean many things at the time during the respiratory season. But if we have the right exposure, we have, some additional signs like conjunctivitis, maybe even the Koplik spots, that then the pre-test probabilities start being quite high. So I have this graph of the different testing algorithms, modalities. And number one is that serology is expected to have lowered sensitivity. PCR may have, again, not the ideal sensitivity before 3 days. And that's a scenario where you could consider checking the urine. That is also a scenario that, like I mentioned, when you could recheck the serologies, because if you look at the kinetics of IgG development, 10 days after the onset of disease, the IgG may turn positive. So if you have a patient that then on second testing has a positive IgM and a positive IgG that will add to only the positive IgM, number two is that you could also go through more sophisticated assays like avidity testing and plaque assays that could also be used to distinguish that. So I just went through the basics of testing, but there is the possibility to use all of those to further support the test. But if there's a high pretest probability, then that patient may have to still be evaluated as if it is a presumptive case.
I just want to highlight one thing that you said very early on in that I think is the most important thing. Right now, measles is not widespread. So really getting the appropriate history of exposure is the primary goal of the first interaction. If someone says, I was at the grocery store and, someone in this town has measles, that's one thing. But if they say, I was, sitting in a classroom with another child for 6 hours and they were coughing and they have measles now, that's a different level of exposure. And I think we really need to be very conscientious of that, or we're going to, be doing testing that isn't going to be helpful.
Great, thanks. Just another question outside of the SOT group and more of the stem cell transplant population. Quite a few comments about vaccination of this population, perhaps earlier than necessary, or earlier than recommended. I mean, typically about 2 years out, it's recommended, I believe Camille said in her talk, but some comments about certain situations, like outbreaks, et cetera, moving to earlier vaccination in these populations, perhaps CAR T, perhaps stem cell transplants. Any thoughts?
I think it depends on the individual situation. So when we always say, this always bothers me that we say stem cell transplant, but we don't differentiate between autologous and allogeneic. And for me, those are like a huge divide, right? So if it's an auto stem cell transplant and somebody's, repopulated their bone marrow and is looking great and like all systems are go, I think you could probably revaccinate them earlier. And if somebody's undergone an extremely complex allogeneic stem cell transplant with a whole host of problems, and they're 3, 4, 5 years out, I mean, unfortunately, we do see those folks, it may not be safe to revaccinate. So I always say you have to calculate what I call the net state of immunosuppression in that individual patient. And I think increasingly we should have what in vaccinology or on CDC guidelines we call shared clinical decision making. And I think it's important to talk to them about risk and benefit, and it just depends on the individual's situation. And I would just I write the chapter for Up to Date on CAR T cell and stem cell transplant vaccinations, and so I've reviewed this. We don't know for CAR T cell. That's really kind of an unexplored area. And so you'd have to look carefully at the individual situation, pre-treatment, where they are now with their disease state, overall, comorbidities, the usual. So I think you have to, I think at this point, I don't know what others think. It's something that's hard to protocolize, but I would say you have to just do shared clinical decision making and think about risk benefit. I also do a lot of travel medicine for immunocompromised patients, and I think that's another area where we're going to have to talk about shared clinical decision making, because there's a lot more measles throughout the whole world, or even for my patients who are traveling to Texas.
Thanks. I had a question, and I know one other audience member did. So just a thought about immunosuppression strategies. I know ID docs aren't always involved tremendously with making their decisions, but for a transplant patient with suspected or proven measles, how is immunosuppression reduction, if any, evaluated?
I
I
can,
know that's a tough one. Sorry.
yeah, I would say that we truly don't know, and then it will depend again in multiple variables, but some of the unusual presentations that happen in solid organ transplant recipients, like giant cell interstitial lung disease and inclusion body encephalitis, they're the result of, there is evidence of the measles virus on tissue. So it is suspected that the reason why they developed these unusual complications is because they had an inability to control the virus. So I think it will be reasonable to reduce, but not all patients are created the same, and not all patients have the same ability to tolerate the reduction of immunosuppression. So I'll say, if feasible, it will be something to consider. The second thing to take into account is that measles is a situation where they will be depleted of T cells. So I think, again, we can conceptualize what the natural course of the disease means, but I wonder if they may not need the same amount of immunosuppression post-measles when they're already in a state where they're going to be T cell depleted and B cell depleted. So I think we can speculate, and I would think that it will be reasonable, but we may learn more in the future. Hopefully we won't.
Yeah, I think, it's so interesting, Ricardo, right? Because with HIV, we thought that they needed less immunosuppression because we thought the HIV was immunosuppressive, and it turned out they actually need a little more immunosuppression. They had higher rates. So it's like, this is all so many unknowns, such a great conversation. I want to just clarify, there's some things in the chat that people might not be able to see, but apparently I know that there are guidelines from the ASTCT about vaccinating people after CAR T cell, that a year out from CAR T cells when the vaccines can start. And those are guidelines. If you are in an outbreak situation or very worried about an individual and you feel safe to proceed earlier, I'm saying that a lot of the guidelines are meant for, large populations. And so under shared clinical decision making, you could potentially do earlier, but you really need to weigh the risks and benefits in an individual. Thanks. So many great questions.
Yeah, it's been nice. So thanks so much. We have come to the conclusion of the webinar. Just to let everybody know that this is being recorded and will be posted on the TTS site for the public. We'd like to thank our fantastic speakers, Lara, Camille, and Ricardo. I think it was really excellent today for the wonderful presentations, very enlightening. And we also like to thank the great questions from the audience. Thanks to all for participating, and have a good day or night. Thanks very much.